psychodynamic therapy, obvious data, because it is very difficult to
treat.
analyze.
I'll come back to that,
But-
exactly.
But for depression-specific therapy, there are three therapies. One is cognitive therapy, one is behavior therapy based on learning principles, and other is IPT, interpersonal therapy. These three therapies are depression-specific therapies, and they have equal evidence like pharmacotherapy.
Yes. So that's what exactly they say, that especially I think when they criticize this paper, this enriched trial, they actually found out the format of the psychodynamic therapy was not uniform. So as you said, that the psychodynamic therapy is something which you have to analyze that person's psychological status right from his or her childhood and go in a stepwise fashion and see what has happened now when you become a heart patient. While doing so, you actually missed there are a lot of missing links. And if you miss those missing links, your data is not going to be correlative. So that is what is important. So the structured psychodynamic therapy is missing. And I think it's difficult, it's not so easy. Perhaps cognitive therapy is more a kind of therapy, a point therapy. Therapy during that point, and whereas psychodynamic therapy is therapy of period. So that may be the reason. But at the same time, we know that conventional stress management therapy may have some role, like yoga, meditation, all those kind of things may have some role. That is psychotherapy. And that is why this kind of patient they get, all these patients, this is a kind of a ventricular tachycardia. Very interesting, you can see up and down, bidirectional ventricular tachycardia. One of the morbid signs of cardiovascular disease, especially in depressive individual. This is another very interesting slide, which actually shows the sudden cardiac death. This is a drug which was prescribed. I think the next slide is there. This is a normal ECG, and then quickly goes into monomorphic ventricular tachycardia, quickly degenerates into ventricular fibrillation, and this is the death. So very quick span of time, there is ventricular tachycardia degenerating into sudden cardiac death. This is one such manifestation when a high-strung individual, for some reason or others, and suddenly we found that he is emotionally outburst and got a heart attack, and very quickly they die. And it is equally to us, it is important for us to remember, if there is a high catecholamine surge, which may cause severe coronary vasospasm, and already if the patient has got a left main disease, they do not get heart attack, but they die suddenly. Because the heart attack does not cause sudden death. Because heart attack takes time, it takes 4 hours time to cause death. Even there is a death after heart attack, 4 hours. So it causes sudden ventricular arrhythmia. So before the heart muscle dies, he dies because of the electrical instability of the heart. That is very important for us to recognize. This is an example. For example, now I think we stopped it here. We just have some more interesting ECGs which I am going to show later on. So after that, we will discuss some of the important drugs which may be relevant in your practice, and it is important for you people to know what are the basic cardiological thing you should find out. One is tricyclic antidepressant. Very common drug being used, and we do find patients on tricyclic antidepressant, and we actually get problem because of cardiac antidepressant. They are known to cause cardiac arrhythmia, particularly ventricular arrhythmia. They also cause long PR interval, which is first degree heart block. QRS may be prolonged, they may get bundle branch block, and QT interval may be prolonged, and T wave sometimes could be flat. It is important for all of us to recognize that these drugs, in fact all drugs being used in psychiatric practice, antidepressive drug, antipsychotic drug, anxiolytic drugs, particularly antipsychotic and antidepressive drugs, the QT interval needs to be remembered. QT interval for a man, if it is less than 0.44 second is normal, and for a woman it is more than 0.46 second. Now it is very difficult because you don't see heart patient, either you are oriented towards ECG. Now how to know which is QT is prolonged or QT is normal? Very simple rule is, you know basic ECG, PQRS. If you find that Q wave, QRST, that end of T wave is less than 50% of 2 RR interval, like PQRST, I can show an ECG a little later, I got it here. So PQRST, and then next R, between the 2 R wave, if the T wave falls 50% ahead of that, not exactly in the middle, little less than in the middle, or even in the middle, that is normal. If it crosses 50% of 2 R interval, that is abnormal. That is a very practical thing. No point of looking at QT and 4.4 or 4.5, 4.6, forget about it. See the ECG, You see the end of T wave, if you say the end of T wave is beyond the middle of the 2-hour interval, that means it is prolonged QT interval. That is important. But what is interesting is that although we are talking a lot, the events happening because of tricyclic antidepressant producing cardiac arrhythmia is not very high actually. It is low. So nothing to be frightened about. It is just to remember that, just to be aware of that, but nothing to be sort of worried about that, well, all patients of your depression on drug will get into cardiac arrhythmia. It doesn't happen like this. The incidence is actually very low. But a word of caution is important, particularly those patients who may be taking some other drug. For example, a patient who is otherwise fine on an antidepressive medication like say antidepressive drug, the same patient got some chest infection or any other infection and give him some antibiotic. That antibiotic, particularly clarithromycin or those kind of macrolide group of antibiotic, any antibiotic for that matter, or quinolone group of antibiotic. Say GI disturbance, went to a gastroenterologist or a physician, give him some quinolone, ciprofloxacin. Ciprofloxacin produces prolonged QT interval. Now suddenly that patient in combination with depression, this drug may precipitate it. So maybe when you prescribe an antidepressive drug, you can assure him that, well, this drug is a great drug from a depression point of view. You will feel your mood is elevated, you are normal. But there is a small thing you should remember, that if you happen to get another drug, or like antibiotic, or for example any other drug which may alter this QT interval, remember that this drug can cause some palpitation. If you get palpitation, do let me know, or hold the drug for some time. So this is single word is very, very useful. That is what would be my suggestion, because the drug itself seldom causes this kind of arrhythmia, but in combination of another drug which producing QT interval. For example, acute ischemic heart disease or acute coronary syndrome, it produces ST elevation, it produces myocardial infarction. But even the cardiologists are not aware that all acute coronary syndrome, all acute ischemic heart disease, myocardial infarction, one of the important marker, ECG marker of acute ischemic heart disease, coronary heart attack, is prolonged QT interval. So the same patient who was otherwise fine got a heart attack and the QT became prolonged. Now the same antidepressive drug actually can precipitate ventricular arrhythmia. And the kind of ventricular arrhythmia that is being precipitated is different. It causes polymorphic ventricular tachycardia and that may cause sudden cardiac death. So malignant ventricular arrhythmia, especially sudden cardiac death, especially during abrupt withdrawal. The other thing, when you withdraw the drug, antidepressive drug in particular, you should not ask, or for example, normally physician or psychiatrist they will not do, but patients themselves, they may stop the drug suddenly, or the non-psychiatric doctors, they think that because this patient came to him, very, very common, lot of doctors, they're non-psychiatrists, they don't have any knowledge about psychiatry, they only think the psychiatrist means madness. You know what I used to believe at some point of time, maybe before this talk. So he says, you are not mad, why you are taking a tablet for madness? Take the tablet off. That causes it. So even a non-psychiatric physician, once they prescribe a drug, they must not advise that stop the antipsychotic drug because they are not qualified to prescribe that. They should say that you go to a psychiatrist and ask whether or not this drug can be withdrawn, and if at all withdrawn, you find out how it should be withdrawn, whether abrupt or slowly, rather than advising or kind of advocating that withdraw the drug because you are not a mad person, you are a healthy person, your doctor is mad, stop the drug. That would be my approach. Any comment on that?
These are all
anticholinergic activity যাদের বেশি তাদের সেই ড্রাগ মানে আমাদের
all the drugs
ট্রাইসাইক্লিক অ্যান্টিডিপ্রেসেন্ট অ্যান্টিcholinergic activity ভ্যারি করে যেমন ডেসিপ্রামিন বা নর্ট্রিপ্টিনের একটু কম
correct
অ্যামিটিপ্রিনের একটু বেশি
for example desipramine nortriptyl has got less anticholinergic activity, so all anticholinergic drug, for example cardiac arrhythmia you give what is called disopyramide.
অ্যান্টিcholinergic যদি থাকে তাহলে তো হার্টের ট্যাকিকার্ডিয়া হয় আমি সাডেন উইথড্র করলে কি সেইখানে প্রবলেম হচ্ছে?
No, I don't know, because it has been recommended that once you withdraw the drug, if you withdraw the antidepressive drug suddenly, then maybe the body is used to that kind of thing, and if you suddenly withdraw, then there is autonomic disharmony. That may cause this kind of problem. Particularly they recommend that you must not, because that may precipitate sudden cardiac death. I don't know the mechanism of that, because it's a very pure psychiatric thing, but that is what has been recommended. Coming back to the newer drug like desipramine and nortriptyline, the norepinephrine uptake inhibitors has favorable effect on cardiovascular system, blood pressure. These are the MAO inhibitors. I don't think it's being used in heart failure. What is your usage in MAO? Gone, is it? That is an antidepressive drug. This is an example. You can get ventricular ectopy in the beginning, like this kind of ventricular normal ECG. This is the ECG. For example, this is an ECG. You can see P, then QRS, then T, then P, then QRS, then T. So you can see this T wave ends. So you got from there to there, you got one big square, two big square, and let us say 1/4 of another square. So this finishes within one square. So this QT is normal. But this kind of ectopic that they get, that's the way to calculate QT interval. And that is what is called Torsat pointis. Torsat pointis is basically an ornament. Ornamental sort of, it's an ornament. It's like a twisted hair or threads as seen on the classical architectural columns, or pointers refer to pointers or peaks. This is the ornament, and the ECG looks like this. That's why it is called Torsat pointis. That is the reason why the name is Torsat pointis. It's a classical example. Now you can see this particular patient has got a long QT, and because of QT, suddenly the ROF comes and quickly degenerates into ventricular tachycardia. This is a patient on early after tricyclic antidepressant therapy. Insustained non-sustained torsades pointis in a patient early after tricyclic antidepressant therapy. In the beginning, right at the beginning, you did not notice the ECG. Do you do routinely ECG before prescribing antidepressive drug or no? Not for all. Because some antipsychotic drug also causes QT alteration. So those things you remember. Coming to antidepressive drugs and heart, the new generation of the drugs may have less cardiac side effect, like bupropion, trazodone, maprodilene, and nefazodone, and metrazepine. But however, bupropion may rise blood pressure. On the other hand, nefazodone may drop blood pressure. There could be postural hypotension. There is a